Great, so I think we will get started. I'd like to welcome everyone to today's webinar titled Everyone Together, Leveraging Resources from the Bottom Up, presented by our colleagues from JSI based both in Washington, DC and Ethiopia. This webinar is the second in a series to highlight the Boost community's Bright Spots initiative. Boost is an on and offline platform that connects immunization professionals to peers, support, and resources to learn and grow, and equips professionals to lead in challenging situations. So actually, before we jump into the webinar and our intro of Bright Spots, we did have a quick poll that we wanted to send out to attendees just to get a sense of where folks are joining from and whether or not they've read the Bright Spots story. Just to give us a sense of where you all are coming in from today. So if you would go ahead and fill out the poll, we'll give everyone a minute or two to fill that out. And we'll just wait another minute or so. Great. So just to give everyone a sense of where folks are joining in from, largely Afro and Paho this morning. And it looks like some folks have read the Bright Spot story, many have not, so we'll be sure to share that out afterwards. And some have started it but have not finished it. So this is really helpful both for us and our presenters today. Great. So from immunization in conflict settings to community engagement to bottom-up approaches to planning, there's innovation occurring at all levels of the system. These Bright Spot stories shine a light on the work that is happening on the ground and seek to inspire immunization professionals everywhere to learn, adapt, and take action in their own communities. The theme of this year's stories is Partnering for Impact, as we showcase how strategic partnership and collaboration at all levels of the system can lead to lasting change. This is the first round of what will become an annual story sharing competition, so please keep an eye out for our upcoming second call for stories, which will be launching in the next few weeks. I'd now like to introduce our colleagues from JSI who will be presenting today. Please welcome Adriana Almagnana, Tewodros Almayehu, and Berhanu Bekele, who are all from the JSI team and will be leading our presentation. So Adriana, I will turn it over to you. Adriana, you're on mute.
Thanks very much. Can you see my screen?
Yes.
Great. Thanks very much to the team at Boost and to all of you for joining today. Good morning, good afternoon, good evening, everyone. My colleagues and I are delighted to be able to share our experience with you today on our approach to improving immunization through improved planning with the community, the use of quality improvement tools to solve problems, and encouragement of local resource mobilization. So I'll begin by giving a little bit of context and overview to the situation in Ethiopia. Then my colleague Tewodros will focus in on our bright spot, which is a story of our work in one district. That's an example of the approach that we've implemented across the regions where we work. And then finally, my colleague Berhanu, who leads our work in this particular region, will provide an update of the current situation and how this region is adapting to COVID-19 challenges. As we go through our presentation, as was mentioned, please feel free to utilize the Q&A box to submit any questions, and go ahead and use the chat box to share any similar experiences or contributions that you may have from your countries. At the end, we'll definitely have time for question and answer, and as well as be able to share some resources and technical guides. So to give us a little bit of background, Ethiopia has made really great progress over the past decades. They achieved the Millennium Development Goal 4 of reducing under 5 mortality reduction by 50%, and they actually achieved this 3 years ahead of schedule. A key input to this was the Health Extension Program, which greatly accelerated the expansion of health services to rural communities by utilizing health extension workers. These are trained health workers, but they come from the communities that they serve. And at this lowest level of the health system, they offer a primary health care package of about 18 interventions, including immunization. In addition to that, the Reaching Every District, or RED, approach to immunization has been the strategy for routine immunization in the country since 2003. But despite these successes, issues and challenges always remain. So today we see that especially in certain parts of the country, there is low immunization, and it is inequitable across different regions. You can see that here in the graph showing Penta 3 coverage from DHIS data in 2016. Some regions have coverage as low as 20%, while others are doing much better in the 80s or even 90s. So before we dive in, we wanted to take a quick poll. We know the RED approach is the main national strategy for the management and delivery of immunization services at district and health facility level for many countries, but it isn't always implemented to the fullest extent in all areas. So we wanted to do a quick quiz. You should shortly be seeing a Zoom poll pop up, and we can just take the next 20 to 30 seconds to test your knowledge of RED. So which of the following is not one of the 5 main components of the RED strategy? Okay, should we go ahead and close the poll, Sarah?
Sure. Do you want me to share the results?
Yeah. Great. So we have a room full of RED pros. The correct answer is advocacy, which most of you got right. Advocacy is certainly an important activity for immunization and for broader health programs. It may be part of the planning and management of resources, but it's not one of the 5 main components of the RED strategy. Great. Okay, so the 5 main components of RED, as we know, are up here on this slide. And our project has worked to improve the routine immunization system in some of the most challenging regions of Ethiopia through what we call the RED QI approach. So RED QI is an innovation designed to help managers and health workers truly put the RED strategy into practice by utilizing quality improvement concepts and tools and adding that into already existing RED strategies and practices for the management of EPI. So RED tells us the what, and RED QI tells us the how. So for example, when we talk about the engaging with communities pillar of RED, part of how we do that is through utilizing quality improvement teams. And these teams include community members, and they're really focused on solving problems and improving the quality of services that are being provided. An added benefit of the RED QI approach is that it's really focused on equity. So it's focused on truly operationalizing RED everywhere and in trying to solve the problems of reaching the most underserved populations. So the project has been around for a while and it's evolved over time. We started out quite small, just working in 3 districts, and then we expanded to over 100 districts in some of the regions in Ethiopia with the most inequity or that had ongoing VPD outbreaks. And then now in our current phase, we've shifted again to focusing our support at a little bit higher level than district. So it's still a subnational level, but more managerial. And with that, I'm going to go ahead and turn it over to my colleague Tuodros, and he can talk about this story of change in Sodo Zuria district.
Okay, thank you, Adriana, and welcome again for all our participants. I am Theodros, working with JSI as Senior Immunization Program Advisor based in Addis Ababa, Ethiopia. And next slide, please. I will start brief background about the project area and the Ethiopian health system. Then I will go to the lesson. The pictures you see on the slide on the left side, that is the map of Ethiopia, and the lesson was documented from southern Ethiopia, shown in orange color, and that district is called Sodo Zuria district. In Ethiopia, we call district, we call them weredas. Woreda has equal meaning like district. So Sodo Zuria district has population of around 130,000, having 6 health centers and 37 health posters. Shela Berkoshe PHCU is one of the health centers in Sodo Zuria district. On the right hand side, the picture shows the PHCU structure in Ethiopia. A health center oversees about 5 to 7 health posters, and the health center together with the surrounding 5 health posters, they are called PHCU. So the lesson that's going to be presented is Shela Perkoshe PHCU, which is found in Sodo Zuria district in southern region of Ethiopia. Next slide, please. On this slide, it shows what were the challenges at the beginning before the project was starting, before the project started to be implemented in the specified district. Routine immunization is one of the core functions of the primary healthcare units, and planning used to be done annually, but there were challenges. So what were the challenges? The planning for routine immunization was based on calculating new targets from previous year performance. That was one of the source of information for planning. The other source was census, but our census is very old. It's over 10 years old, and the current information is much different from the information what was there at the time when the census was done. That is another challenge. Then the third issue was the planning was mainly top-down type of planning process that start usually either at the region or at the district level, and it's cascaded to the health facilities. And usually it was being led by the health facility staff. So the planning process for routine immunization was mainly led by health facility staff, plus it was more of top-down type of planning. Then the other key component was lack of input from local community leadership and non-health stakeholders. That was another challenge observed at the time when we start the project. In the context of Ethiopia, the district administration, which we call them non-health stakeholders, they have direct role in allocation of resource to the district health system. So it means they have a role in decision of the resource to be available at health center and at health post, which will affect the routine immunization programming at those areas. So what was the effect of having this type of challenge? The effect was there were children that were missing out of immunization service, as it can be seen between the administrative data and the DHS data, which was presented by Adriana before. There was gap. Then the type of data, there was the quality of the data was poor, and there was no enough resource available for the health system to expand the service. So these were the 3 results of having issues related with planning. Next slide. On this slide, the project, it shows the series of activities completed by the project in partnership with the district health administration. So the first activity completed by this project was Red QI training. After doing some preliminary assessment, the project provided Red QI training. The trainings provided skills and tools on microplan and quality improvement. The process of bottom-up microplan, what does it look like, bottom-up type of microplanning? Then what are the roles of various partners and stakeholders, and how or ways of identifying bottlenecks for routine immunization? These were the areas where the Red QI training is focused, mainly microplan and quality improvement. And on the training, one of the particular phenomena of this training is the training included all key stakeholders. It includes from health system, like from health center, from health post, and district health office. There were also participants from community and non-health stakeholders or local authorities also participated in the training. This makes all these people to be aware on what are their responsibilities, what will be their contribution, and the type of activities to be completed at the community level. The other activity completed was head count in all villages. Head count means identifying and registering every eligible child in a given village. That was completed by health extension workers or community with assistance from the community leaders, and all the children in the villages and qabalis were registered. This brought new information, and the health facilities were able to obtain verifiable data for appropriate targeting. It shows how many children are found in which village. That type of information was available for the health facilities. During the process, it was realized that the number of outreach or immunization sites were not enough. The number of immunization sites were insufficient. So using this new information, microplan was developed. It has the detailed information, how many children are found in which place. Then that was used as source of information, and a new microplan was developed. During the process, with the community participation, decision was reached to expand the number of outreach sites, because they have realized, the facilities have realized there were insufficient number of immunization sites, and the number of outreach sites were increased. Health facilities start to use planning for routine immunization, and the routine immunization sessions plus monitoring the progress of the immunization start to use the new microplan. So the microplan, one, it's used for expanding the number of outreach, and it's also used for planning sessions plus for monitoring the progress using the new microplan. The microplan, beyond its technical area, it was also used for other purpose, like the microplan was used as evidence for constructing new health posts and deploying health workers to address the hardest to reach sites. There were sites that were difficult to be reached by outreach, and discussion was made with the local authorities on constructing health posts, additional health posts, and the microplan became evidence that there were villages and areas that cannot be reached by the existing health facilities. The other good component of activity is during the process, it was realized that there was no enough resource for expanding the service. So the district health office and the health center used the microplan as an advocacy tool for local decision makers for allocation of additional resource for the immunization service. These were series of activities that were conducted for developing microplan plus using the microplan for immunization as well as for resource mobilization. Next slide. As mentioned in the previous slide, quality improvement was one of the training as well as the activities integrated in the process. So on this slide, we'll see the role of quality improvement tools for local problem solving. Quality improvement tools and immunization management process were systematically integrated. The project integrated both the routine immunization programming with quality improvement, and the integration was at the planning level, during the training, during monitoring of immunization activities. It was systematically integrated. That was one of the character of the project approach. There are a lot of quality improvement tools, but for this particular project related with immunization, selected quality improvement tools were used. Some of them were fishbone diagram for root cause analysis. The one that you see on the picture is fishbone. I will come back to it. Other type is participatory mapping, PDSA or plan, do, study, and act type of cycles were used. So these were some of the tools that were used by the quality improvement team for local problem solving, identification and solving. And usually this quality improvement, it has a lot of jargons, a lot of tools, and there was a need to simplify the concepts, the language, the process, as well as the tools, so that it can be used at district level, at health center level, at health post level, and even at community level. So there was a process of simplifying the concept, the tools, and the process, so that they can internalize, the community can internalize the approach for problem identification and solving. So during the process, what happened? In the process, the partners, the stakeholders, as well as the health facilities understand that planning was no longer the exclusive responsibility of healthcare workers like what was there before we start the process. Rather, the partners and stakeholders, as well as the health facilities, they realize that it needs multiple partners' involvement. The picture that you see on the slide, it is fishbone diagram used in the health center to identify the root causes for low fully immunization coverage in the district, in the health facility. So as you can see from the graph, the quality improvement team of the health center identified number of reasons for low coverage and grouped them into 4 broader categories. Then they identified one of the issues, one of the areas, and start to address that issue. So this is practical, the type of quality improvement tool used to address local problem related with routine immunization programming. Next slide, please. On these slides, it is pictures that were taken from health facilities that shows how quality improvement teams in health facilities applied the different type of QI tools. For example, on the left side, you see fishbone for addressing the high dropout, penta-1 to measles dropout rate. And they identified various root cause. Then from that root cause, they target, I think the one that is shown in rectangular box, it is poor defaulter tracing. That was the area they focused to address the high dropout rate in that particular facility. Then on the right-hand side, you see three different type of QI tools: PDSA cycle, run chart for monitoring their target, and another fishbone for low coverage of penta-1, I think. So these were practically the type of tools that were used in local problem identification and local solution based on the problem. Next slide. So in the next few slides, I will be focusing on what will the effect of this bottom-up participatory micro-planning in improvement of the routine immunization programming. Healthcare workers understand which operational issues have a stronger effect on their daily work for immunization. Is it session planning? Is it conducting outreach? Or is it related with defaulter tracing? Because of the use of quality improvement, it enables the health workers to identify which operational issues are most pertinent to address the challenge they observe. Then another area is the microplan become an advocacy tool for mobilizing resource. We will see it in the next slide. Next slide. So in Shela Perkoshe PHCU, the one that we started initially, based on the micro planning, there was 21% increment in funding available in the PHCU following the new micro plan, because on the new micro plan, they observed there were gaps in terms of sites plus the number of sessions, and there was a need for additional resource that was presented to the body responsible for addressing the resources, and there was 21% increment of resource for that PHCU. And using that resource, additional 7 new outreach sites were added, and 84 additional monthly immunization sessions were conducted in 2018. And this practice was not isolated for one particular year. The practice continued for the next for the next years, allocating resource using the microplan. This was one of the success of the microplan used for advocacy for resource. Next. On this one, what we see is in Sodo district. As I have said it, as I have mentioned it before, the PHSU is found in Sodo Zuria district. So what happened in the PHSU is just an example of what happened throughout the whole district. For the entire district, that is for Sodo Zuria district, there were 396 additional outreach sessions conducted in the year. That was because of one, there were 3 reasons for this one, just that's summarizing. One, it was bottom-up micro planning process that involved the community. That was the first one. The second one was the reason, using quality improvement tools to break down problems and identify solution. And the third one was focusing on increasing the local resource funding where it is needed most. So this is another area where the micro plan become an advocacy tool for mobilizing resource. Next slide. Summarizing, what was there before the project started? The issues were poor planning approach leading to inaccurate data. The number of outreach sites were not sufficient, particularly for the hardest to reach areas. Missing community voice and participation of local leaders was another issue at the beginning of the project, and the resource available for immunization service was not enough. And after the project, the lesson was bottom-up micro-planning approach using quality improvement tool and more accurate target data. That was one. And the project was able to expand reach of routine immunization and health service. It also reinvigorated the community and local leaders engagement. On that one, local community and community leaders engagement was observed during planning as well as implementation of the project. Community identified appropriate sites and dates for outreach. They also helped in addressing routine immunization, like active participation during defaulter tracing, mobilizing community to attend routine immunization. So there was an active participation of the community, not only at the beginning, even during implementation. And after the project, there was also increased local resource available for routine immunization. So what was the lesson? There were a lot of lessons, but the main ones, we have summarized the 3 top ones. The first one was focusing on often overlooked but crucial costs. There are costs that are needed as crucial, but they are overlooked. Ensuring funding for operational costs like transportation costs for outreach, or it might be for supportive supervision, or it might be for training, should be emphasized. Not only for the technical, but the operational cost also should be considered. And engagement with non-health stakeholders, like in our case, district administration, yielded greater buy-in and funding available for routine immunization service. That was one of our lessons. Then the second one was recognizing the value of the community in programming. Knowledge and contribution from the community was critical to help health workers plan more effectively and ensure no one was left behind for services. Quality improvement teams that include community members were able to solve problems more effectively and foster accountability. That was another success that we saw because of our partnering with the community. And the last lesson in this slide is adding to the toolbox of path workers for expansion of primary health service. The micro plan was an evidence-based document that made clear the need to expand services to areas that were underserved. Sodo Zuria district, the one that the lesson was documented, eventually began building additional health facilities to some of areas that previously only received immunization sites. There were additional health facility constructed because the micro plan was used, and that enabled the facilities to construct the community to access not only outreach but even static, and that the micro plan becomes an effective tool for immunization. So with this, I will end my presentation, and my colleague Brahanu will tell us about what happened in the district after the project ended and where are we focusing currently. Thank you.
Thank you, Teddy, for your intensive presentation. Please, Adriana, will you go to the next slide? Yes, thank you all our participants. So I want to mention some activities that is sustained at the district level after the support of the project in the woreda in 2018. So when we come to the issues of sustainability, some of the activities that are sustained at the district level was ownership of microplan in development and implementation is sustained at woreda level, at district level, after the project support ended in 2080s. For that, what is the indication for that is the district has 47 static and 77 outreach sites so far functional in the district after the end of the project support there. The other thing is they exercised using headcount for the micro planning, as Teddy mentioned in the earlier presentation. So still they are using their headcount for micro planning purposes. Another thing is they are exercising micro planning in consecutive years by giving refresher training for the health workers, health service providers at the facility level. This is exercised at the beginning of the project and now sustained until now. At this time also they are using QI tools which we are exercising with them during our project support in the district. So they are exercising these QI tools for the other activities rather than QI, so routine immunization only. During our support at the district level, we are exercising QI tools like fishbone diagram for root cause analysis and another tools like driver diagram as the district level. They used this tool for the other activities too. So nowadays they are using these tools for 23 key performance indicators to measure what's the challenge. Some activities are stuck there. So they are using these tools. What is the reason for that for that activities to be stuck there? So they are using the QI tools. Nowadays, zonal health department or sub-regional level managerial unit is strongly supporting the district, and so district is maintaining the service that they are doing for. The other thing is we engaged a number of non-health professionals from the district authority. They are trained on the issues and they know the issues, and nowadays they are allocating budget for funding for the activities to be accomplished as a woreda. So this is one of the critical things which we have faced as a challenge, and now leadership engagement is critically observed at the district level. So this is one of the things that I maintained or sustained as the woreda level. Please, can you go to the next slide? So currently what we are doing with the region is, at the sub-national level is, we have, as Adrana mentioned at the beginning, our project support is shifted its intervention level to the higher level, to the sub-national and the sub-regional level. So currently we are supporting technical assistance at the regional and the sub-regional levels. So currently we are supporting 5 regions, 2 zonal health department, 11 waradas in the Ethiopia. So our current support focuses on the capacity building activities at regional and the sub-regional levels. That means at zonal level in Ethiopia context. So during that we identified some tailored training or capacity building activities to the lower level by giving training, by coaching, supporting them at the lower levels. As the other thing is improving equitable service provision is one of our focus areas. Now we are working with different levels. Other thing is strengthening partnership collaboration in the region or is a sub-national level is one of critical area we are working with the regions. We are strongly engaged at the regional level, at the zonal or sub-regional levels and working with them. This is the area which we are focusing now. The other thing is sustaining health system strengthening effort as the level is very critical for routine immunization activities. You know, this routine immunization is very critical for health system strengthening, so that we are working with them. So supporting sub-national managerial units, that means sub-regional and regional level is very critical, and exercising RAID care activity at the lower level is observed directly at the district level now. So we're doing with the districts to maintain this issue from the beginning, and they maintained this, and they are doing after the end of the project. Project support ended in the 2018. Can you go to the next slide, please? So as a regional level, what we are doing now is institutionalizing and strengthening routine immunization service is the critical area we are doing with Regional Health Bureau with other partners in the region. So scale up of both of microplan approach across the region is the critical area which we are advocating, and also we are practicing as a ground now. The other thing is developing and adopting standard guideline for updating microplanning for regular purposes, one of the critical areas, because once as a project intervention time we can do with a different level, and we can exercise some intervention at the lower level, but this should be maintained. So what we're doing is we have developed the guideline for the updating. So after the project support end, even they can use this guideline for updates and microplanning, as this is critical tool. We are working on it. The other thing is building capacity at managerial level, sub-national and regional, sub-national and sub-regional level is very critical. So we are doing with RAID QI training, especially focusing on microplanning and the quality improvement. So in this quality improvement approach, we give special attention during coaching, especially supportive supervision. So in supportive supervision, we are doing 2 types of supportive supervision. One is integrated support supervision, overall support for the regional level, and the process-based support supervision for MCH Directorate. So we are working strongly with them, and it is bringing some contribution for their RI, improving data quality issues, especially improving data analysis and the use, especially data triangulation from different sources. One of critical area we are doing with the region. So this is contributing for RI so far. Please, next slide. So adopting RI service delivery during COVID-19 pandemic is one of the critical area we are working nowadays. So when we see what was done at the regional level is during COVID-19, what the region did is we established, the Regional Health Bureau established 2 teams, one for COVID-19 and one for essential health service, including RA services. After establishing these 2 teams, what follow is developing guideline for how essential service should be guided during COVID-19. So guideline is developed for essential service, including routine immunization service. So this is very critical areas. So this has helped us. After establishing a team and developing guideline, what followed is the follow-up of the intervention based on the guideline. So monitoring intervention of service through data, especially support supervision conducted to the low level 3 times from March to now by support of Regional Health Bureau. During that, we are observing how routine immunization service is guided during pandemic. So there is no session that is interrupted during both in static and outreach. We observed during our support supervision. What was the issues of prevention activities that are related with COVID-19 during the session? was we regional health bureau supported the labels including Sodo districts, face mask for service. The other thing, hand sanitizer for the service provider, social distancing issues given attention from the regional health bureau, and we are working with them and supporting to the RHB or sub-national level, and it is contributed a lot so that there is no such high number of vaccine treatment pandemic is happened in the region due to this COVID-19, and the service is not interrupted so far. This is our experience in the region. Thank you. This is my presentation. If you have any question, we are welcome.
Great. And just to wrap up quickly before we go to the questions and answers, we wanted to share just a few resources that we thought you all may find useful in your work. So we have many resources on our website that you can feel free to check out, but we wanted to highlight just a few. I will post 3 resource links in the chat box. We have one that is a quick reference guide for how to implement quality improvement tools and methods. We also have a job aid on the fishbone method, which helps basically diagram out a problem's root causes, as you saw when Tewodros was presenting. And then we've also recently developed guidelines on how to routinely update and monitor microplans. And that document, as we mentioned, has just been taken up and owned by the SNMPR regional government. So again, I'll post those 3 resource links in the chat box. Thanks again, and I think we are ready to move on to the Q&A.
Great, thanks everyone. And also just to note that we will share out all of these resources along with a recording of the presentation, both via email and on the Boost platform in case you missed them in the chat box. Great, we've gotten a few questions already, and I would encourage others to submit questions either using the Q&A box or the chat box. We'll be sure to monitor both. So the first question is, how are mobile populations addressed in the listing of children?
Okay, thank you. The presentation that was presented, it was from non-mobile population. It was sedentary type of population, and that was why the focus was, the strategy was mainly either static or outreach type. But in terms of our experience, our project works in both pastoralist and non-pastoralist, or in people that are moving from one place to another place, and in sedentary. So our experience showed that in pastoralist, in areas where people are moving, the community leaders, particularly clan and sub-clan leaders, they have detailed information on who is where at what time. That is one. And in terms of even the populations, in terms of the family size, they have that detailed information. So the clan leaders, the sub-clan leaders, we are using them as source of information for revising microplan equivalent to household registration. That is the current practice. Thank you.
Great, thanks, Teddy. Another question is, Ethiopia had a recent measles campaign. Were these microplans useful or used to do SIA planning? If not, why? And if yes, how?
Brahanu, if you respond, then I will supplement. Or Adriana. Brahanu.
Thank you, Teddy. Yes, we have used microplanning for measles SI too, because even we have prepared microplanning for SI before the SI, ahead of 3 months for SIs, and we used this and revised 2 times because of COVID-19 happened between after our microplanning. Then we revised as a regional level. All regions revised its microplanning, including our region. So in our region worked strongly on microplanning process. Especially we advocated for head counting for microplanning, and some sub-regional levels conducted head counting for their microplanning, including Sodo district. So we used microplanning for SI too. And this helped us, and we were successful in microplanning SI measles campaign implementation. And during post campaign, we conducted a rapid covenant assessment in different sub-regional levels, and it was exactly similar with admin report we get from the administration level. So microplanning is very critical, and we used for measles SI too. If you,
Good.
Teddy, if you anything would you want to add, you can add on it.
Okay, good. Thank you. Just to supplement, yes, in terms of development of microplan for the SIA, yes, it was developed. In terms of using the microplan of the routine immunization for the SIA, it was not used directly, rather because of the age group difference. The routine immunization target and the SIA target were different. So there was a need for developing new microplan for the SIA. That's one. Then the other thing, the skill, the experience, the regional health bureaus as well as the district administration, the skills they have from the routine immunization microplan has helped quickly and bringing the experience of the routine immunization for development of the SA. So even if the routine immunization microplan was not used for the SIA because of the target group, but the experience they have from the microplan, it was applied for the SIA. The experience and the skill. Thank you.
Thank you both. A few more questions coming in. How was the community motivated to do community mobilization? What was the reason for their motivation? And how do you evaluate the different community leaders' performance?
Adriana, if you add, then if there is anything, I will supplement.
Sure. Yeah. So when we talk about the community, we're really talking about kind of two different aspects of this. One may be certain community members who we tried to involve from the very beginning of microplanning. So really going to them or having the health facility staff go to the community and talk about where are the best locations for outreach, where could we really use another site, where are we not reaching everyone. And so some of that community engagement really started at the beginning of that microplanning, where we're, basically asking how can these services serve the community better. So that was one aspect of it. And then the other part of the community engagement was really at kind of that higher level at the district, the non-health stakeholders who, the health is maybe just one of their many priorities, but we work to engage them again at the very beginning of the microplanning process to really bring them on board and have them, really understand the importance and the value that immunizing everyone in the community brings, right? So it's not always easy to get their time. And I think a lot of credit goes out to, the health facility staff, the district staff for that kind of continued advocacy. But all of that essentially kind of comes together in different ways. And everyone basically contributes in a different way to be able to come out with, essentially a community informed microplan that will be implemented and funded.
Okay, good. Thank you. Just to add two additional points. As I was presenting on one of the lessons, the second lesson was related with that, the community engagement. So it was the health workers together with the community members being in the same platform, discussing issue of community, trying to understand, to address that issue. It was motivational factor by itself for the community because it's recognition of the effort of the community, either for selection of site or for additional site for immunization or for default tracing. So that recognition of the community effort by the health workers in the same meeting by a quality improvement team, that was one of the motivational factors for the community. The other thing that the project tried to adopt throughout its implementation is not creating parallel structure. As much as possible, the project was trying to use what is existing structure in the community. What is existing structure at health facility level? Is there any committee that exists? Then that committee, that structure, those existing committees, they were given orientation and how to use tools and what could be their potential contribution to routine immunization. So that one also helped for not bringing another committee, another structure, because the existing committee or structure was used. That is another factor that helped the success of the project. Thank you.
Great. So we have a few more minutes. I think we have a few more questions we can get to. Another question is about integration of services and planning. What services have been integrated, and are there other programs or campaigns which have integrated with RI services, particularly in the COVID-19 context?
Yeah, so I can take the first part of that question. So one of the focus areas that we have now is kind of exploring the integration of both planning. Is it feasible or useful to utilize the microplan to plan for other kinds of services, and then also in the delivery of services themselves. So can we have RI sessions that are a bit more enhanced and offering additional services at the same time? So we are basically piloting this idea right now. We in 4 different districts, and what we've been integrating is selected nutrition services, because that was, we did some formative research, and that was both a need, but also there's some low-hanging fruit there in terms of, being able to integrate counseling and ensuring that growth monitoring happens every time, even if you're going out on outreach or mobile. So there was some synergies there between immunization and nutrition that we felt that we could kind of choose some interventions related to nutrition that may be useful, and that also serves to expand services, both for immunization and nutrition. So that is definitely a work in progress. I think integration is always tricky because you have really very real barriers and to operationalizing it. You have very real barriers of human resources to be able to carry out integrated services. In some cases that might mean longer wait times for clients. So we're trying to take a look at that. Right now, we certainly don't have all the answers, and we're trying to really figure out what makes sense. And then also on the planning side, is some of that integrated planning really a value add for programs outside of immunization?
Thank you, Adrana. Can I add more some detail about COVID-19 era issues which we are trying to integrate at the field level?
Yes, definitely.
Yeah, currently what we are integrating at the ground level is during the session, our health extension workers are screening caretakers and the children for COVID-19, especially fever screening is integrated. The other thing is, due to the COVID-19 issues, health extension workers are conducting house-to-house screening in selected areas in the region. So what we are integrating as the ground is they are conducting surveillance for the COVID-19. So we integrated vaccine preventable disease surveillance activities in screening in COVID-19 intervention, so that we are trying to consider current situation with routine immunization activities at the ground level. Thank you.
Great, thanks, Berhanu and Adriana. So I think we maybe have time for one final question, and actually this is one that has come up previously. So I think for the panelists and presenters, what do you think is the top takeaway for a district level immunization professional who's watching this webinar and trying to understand how they might be able to implement something similar in their context? What would be sort of the 1 or 2 things that you would share either your lessons learned or starting points. I know, Adriana, you had shared the tools, but just what advice would you give based on your experience implementing this project?
Adriana?
I can share one and then pass it off to my colleagues. One thing I think that maybe we don't always talk about. So you know, if you're thinking about embarking on something like quality improvement and really starting this kind of change is really and truly like thinking about it from the point of a manager and what kind of you know, what kind of attitude and ecosystem do you need to be able to allow for that change? You know, we found that, you know, at the lowest level of the health system, they really, you know, they have the solutions. They know what they could need to change. It's just a matter of, you know, maybe empowering them or giving them a little bit more resources to be able to do that. But, you know, people often, when you put them together in a room, they will have the answers to problems, right? And so how, you know, how can you, and so thinking about how can you as a kind of manager allow for that kind of change and allow for that flexibility and creativity to allow people to empower them to find their own solutions. That's one thing that I would share.
Yeah, yes, I can add one. It starts from the beginning. From the beginning with the district, what we did is, what are the things that we are going to do? The project is set the expectation from the beginning with the district health office. Then what are the things that are going to be done at community level? How they are going to do the activities? That was setting the expectation, helped to facilitate for motivation, for implementation, and for follow-up. That was the first. The other thing is quality improvement for the community, even for the facility. The concept was new. They do the community as well as the health workers, they have meeting discussion, but the use of quality improvement was something new. So we did two things. One is training, because it is a new concept, it needs proper training for the participant. Then the other is, it's not that big quality improvement concept from the theoretical. It needs to go to the ground to make it simple, applicable, and understandable by that community, by the community and by the health workers. So simplifying the tools was another lesson that we learned, and it is something that needs to be considered for adoption of the quality improvement to the lower level. Thank you.
I can add one. What we have learned at the ground is, especially concerning quality improvement, it is very challenging as a community level, but what is very contributing factor is quality improvement approach is spiral learning, so that doing it again and again with the community can contribute more for the communities, especially for routine immunization. It is a new approach. So what we did is doing again and again, the steps which we are included in the quality improvement at the community level should be repeated again and again to the community. So that is why quality improvement is spiral learning, so that we can exercise it again and again, then it can make you successful in your intervention. Thank you.
Great, thank you everyone. I think we are just at time right now. So as I mentioned earlier, share my screen again. We have a few follow-up opportunities here. We would invite everyone to join or visit the Boost community if you are not yet a member. As we mentioned, Boost is a free online platform for immunization professionals to connect with their peers and gain access to resources related to both technical and adaptive immunization issues. We also on there have created a learning group for Bright Spots. So this is a space to continue sharing your comments, questions, gain access to our panelists and other Bright Spots story submitters. And we will also be posting the presentations and resources in that learning group. And then we do have a brief survey that we would ask you to take. This is, you know, our second webinar, so we're learning and we're always looking to improve. So we would welcome your feedback there. I also will say that Denise Traykoff from CDC has offered to provide perhaps a bit more training around fishbone diagrams. So perhaps that might be coming in the next few weeks. but we'll be sure to advertise that as we get that planned. So again, thank you everyone for joining today. And thank you, of course, to our presenters. We will be sharing out the recording and the additional resources that Adriana shared later this week or early next week. So keep an eye out for that. And of course, feel free to reach out with any feedback or comments. Thanks, everyone. Have a great day.
Thank you.
Thank you. Bye bye. Bye bye, everyone.
Bye.